Hi, good evening, everyone. Thank you for joining the meeting tonight. We want to remind everyone that the meeting's being recorded. So please contact the MHCC team with any technical issues. So we are excited to have so many people participating today. We anticipate having about 55 members of the public in addition to some committee members. So we do ask that the members of the public remain on mute throughout the meeting. As a courtesy to others, please remain on mute when you're not speaking to reduce your background noise. Staff may mute you if there's a lot of background noise coming from your line, but you can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to ensure we have a wide range of perspectives. If you have questions, please raise your hand by clicking the raise hand button under reactions at the bottom of your screen to ask the question. Another option is to enter your question into the chat box. We may have a lot of questions today, so we'll answer questions as time allows. If we're not able to get to your question during the call, we'll post responses following the meeting. I'll now turn the meeting over to the MDPCP Advisory Council Co-Chair, Dr. David Sharp, to make opening remarks.
And good afternoon, everyone, and welcome. And thank you all for taking time out of your busy schedule. We are very fortunate today to have a number of distinguished presenters from the Maryland Department of Health, and we're looking forward to getting started. Just to remind everyone who's with us today, our team at the Maryland Healthcare Commission, that was Melanie Cavalier. We have a few technical people behind scenes, so if you run into any trouble, use the chat. We're monitoring it. We will post the list of attendees and the summary of discussion today, along with any questions. Hopefully, we're not going to encounter any technical challenges, although I see just an M on the screen. I don't know for the team here if that needs to be, we need to take a look at that. But we'll keep moving while the team tries to figure this out. With that, I'd like to invite the co-facilitator today, Dr. Michael Riedman, to make a few opening remarks himself. Dr. Riedman, are you able to join us?
I sure am. Thanks, David. And I'm going to echo what David said and really welcome everybody. I'm going to cut this short. We've got a long agenda and we have a hard stop as usual at 6 o'clock, and we really want to try to get to the agenda. But thank everybody for coming. I'll have a couple of more comments when I think we get down to the MDPCP and some personal comments about how the program's working for our practice. But I'm going to turn it over to and let Ben say a few words and for a couple of seconds, and then we'll kind of move right into the agenda if that's okay.
Sure. And before before Ben makes a couple remarks, can the team test the technology to make sure that the slide presentation or agenda is working? It looked like from the viewer standpoint, there might be some challenges suddenly. Okay. So this is the agenda, and we will, as Dr. Riedman noted, we'll invite our executive director to say a few words. Ben, are you able to weigh in?
Sure. Thank you, David. And I took my cue, a few words. I want to welcome the health secretary, the deputy secretaries that are here, and thank all of the MHCC, HSCRC, and department staff that have put forth a lot of effort over the last month to plan this trilateral commission of the three primary care groups that have really worked in a dedicated way over the last several years to really elevate the importance of primary care. We have a wealth of options. The recently released Medicare fee schedule outlines additional options for core primary care as well under Medicare. So I'm excited to hear the discussion today, and I want to thank you all for the commitment for a couple hours today and welcome the feedback that I think we're likely to receive. So David, proceed.
Thank you, Ben. And Dr. Riedman, do you want the pleasure for the introduction of our first presenter?
I will take that pleasure. So I think everybody on the committee knows Dr. Laura Herrera-Scott and the Secretary of Health for Maryland. It's good to see you again. I've seen you a couple times now virtually. and she's going to give us an update on the AHEAD program, and I'll look forward to her comments. So I'll turn it over to her.
And we'll bring up the presentation, Mac, and I think Dr. Scott, Secretary.
Thank you, Dr. Reedman. I was talking, I was on mute, so forgot to do that core basic function to start the meeting. So
no worries. We'll bring up your presentation. Can you, Mac, can you bring that up for us, please?
great, thank you. So if we can go to the next slide with the agenda. So we did the welcome and introductions. I'm going to spend a little time talking about the AHEAD state agreement and where we are. Talk a little bit about Medicaid, primary care, APM, MCPCP updates, or this is your actual agenda. My part is just the AHEAD state agreement update. So if we can go to the next slide. Sorry, I was not paying attention that it's the same agenda we just had up. So, as many of you know, we've been in discussions with CMMI for some time related to the next model agreement. And in March of this year, we applied for AHEAD, which is the all-payer health equity, advancing health equity and advancing developments, I think is the title. And then we learned in May that we were awarded the proposal, which is a 10-year agreement, and there's $12 million, which is just $2 million over 6 years to help develop the model and staff up the model. But one of the elements in the agreement is related to primary care and the future state of primary care, which is the inclusion of Medicaid. So late last week, we got the agreement and we've been spending the last few days going through. So we're going to be sharing some high level details of where we're at and things that we still need to talk through. Next slide. So this was the vision that we had set out when we first, or at least certainly when, we first came together as a team, and we, as in some of the leaders on the Department of Health, which are on the phone, on the call now. Under the prior versions of the model, there was no, at least what, from my perspective, what we thought was lacking was just like a mission and a vision. And yes, the model was designed around total cost of care, but what was it that we wanted to achieve? And so this was one day of brainstorming. We came up with this vision of equity and excellence in Maryland's healthcare delivery system that improves the health of all. And this was even before AHEAD came out. This is the vision that we had put in place. And we know that a lot of work had been done in primary care. A lot of work had been done in post and hospital care. Public health does a lot of work in community, but it's not always coordinated with primary care. Some work with EQIP in specialty care, but really not that much done on the end of life when we think about post-acute care, palliative care, and end-of-life care. So we wanted to call those things out because we thought it was really an important component of the delivery system and the continuum of care. And we recognize that primary care is incredibly important as we think about where you go through the continuum. So I'll spend most of the time talking about primary care, which is the purpose of this call, but did want to lay out the full continuum in the way we had thought about it even before AHEAD. And certainly under all this is equity, community, and population health. I would also be remiss if I didn't mention data and workforce. So those have certainly been front and center in the work that we've been doing. Next slide. So states advancing all-payer health equity approaches and development model, and it is the next version of the current total cost of care model. When you look at the details of what we have, total cost of care growth, Medicare and all-payer, primary care investment, we certainly have the Medicare part, and then cooperative agreement funding and hospital global budgets. This is basically the Maryland model. It's just taking it to the next level. And what's new in this model is not only primary care AHEAD, which we are defining as the inclusion of Medicaid, and what does that look like, and what is the implications for Medicaid being at the table for MCPCP. Certainly the behavioral health integration. So how do we build in behavioral health resources into primary care or other parts of the delivery system to make sure we're adequately addressing behavioral health as part of overall health and managing cost of care, and then accelerating existing state innovations. So the state has been incredibly successful under this model and has bent the cost curve significantly. But as we think about the next steps, it's going to be a bigger lift. And so how do we pull all of these things together while also integrating equity across the model and across that continuum of care that I just showed you on the previous slide? Next slide. So if we looked at the requirements for primary care and what they're expecting, as I said, Medicaid primary care as an alternative payment model, and you'll hear more about what that looks like for Medicaid in a few minutes. Recruitment. So MD-PCP has over 500 practices. Medicaid could have approximately 500 practices depending on the attribution method. We have done the crosswalk looking at TINs to see how many practices would automatically qualify based on the number of Medicaid beneficiaries that they take care of. More under development there. Care transformation, so integrating behavioral health care as a function of primary care. Some of you may know, or maybe all of you know, in Medicaid, we do have the collaborative care model that was originally as a pilot and just went statewide. So there is reimbursement opportunity for the integration of behavioral health care into primary care. Enhanced care management and specialty coordination, which exists in MD-PCP, and I know many of our MCOs do this kind of work, but how do we get alignment across everyone? And then of course, addressing health-related social needs of beneficiaries, which some do, some don't, and it's patchy at best, but how do we ensure for those individuals that need those things addressed, we're addressing them for everyone? Commercial alignment is certainly encouraged, and Care First, Maryland's largest commercial payer, has been aligned with MD-PCP. And then accountability. How do we use our data to develop targets and measure progress? Next slide. So key goals of primary care under ahead: increase investment in primary care as a proportion of total cost of care for Medicare fee-for-service and across all payers. So right now, I think if we use the primary care investment work groups targets, though what qualifies as a primary care might be a little different, at least based on the percentages that you've defined as the goal, we're doing okay. But then what incrementally do we need to do over and above the practices that are currently in MD-PCP? We have to align Medicare's primary care strategy with efforts already underway in state Medicaid programs. So how do we integrate and align the care management that either the MCOs are doing, the hospitals are doing on behalf of the beneficiaries, or the practices are already doing by virtue of the fact that they do it for all their patients, regardless of payer, behavioral health integration, and then referrals for health-related social needs. Some providers are billing for, or at least capturing Z-scores. Some are just making referrals. But how do we think about a statewide tracking process to figure out who's getting referred to where, and how are we closing the loop on those referrals that we're making? Target populations most in need of improved access to high quality primary care by ensuring that FQHCs and RHCs are part of the Medicaid primary care program, and then think about adjusting payments for medical and social risk given the particular needs of the patients they serve. And then we certainly want to encourage more providers to build increased capacity to deliver advanced primary care. And what does that look like at the practice level? And how do we support practices where they are in their journey, but help them move through the different tracks, for lack of a better description, as we evolve under the new AHEAD model. Next slide. Key components of the National Primary Care AHEAD will be a Medicare enhanced primary care payment, and this will fund the advanced care management and behavioral health integration. Primary care practices attributed to Medicare fee-for-service beneficiaries. So So this will be for net new practices, not for practices already under MDPCP. The EPCP will be adjusted for social and medical risk, thinking about care transformation requirements. As I mentioned already, integration of behavioral health, enhanced care management, and how are we assessing and referring for health-related social needs. And then under Medicaid, care transformation requirements, and then aligned quality measures between Medicaid and Medicare in the advanced primary care programs. I know it says Medicaid and Medicare, but we're looking at this for everyone because, you know, the more the measures don't align, we know that is administratively complex for practices to administer. So the more that we can align to a core measure set, the easier it will be for the practices, regardless of the program that they're in. So I know this says Medicaid and Medicare, but I'm certainly shooting for alignment across the board where we can. Next slide. And then primary care elements in the state agreement. We do have to have a primary care Medicare fee-for-service investment target and likely targeted toward increase in participation in Medicare model and out years. I can say it is targeted towards increased participation in Medicare in out years. Medicaid first participation, and this is likely in 2027, so we'll likely have a transitional year for 2026 as we move towards Medicaid participation in 27. So that will be the gate for staying in a primary care program. Again, we're still working out the details on attribution and what that looks like. And then availability of primary care ahead track alongside MDPCP, which is under discussion. So there's not enough details to be clear on what that looks like. And so that's some of the follow-up that we're working on right now. So I went through the elements and some of the terms of the agreement pretty quickly, but I'll just pause there and see if anyone has any questions for me. I see one from John Miller that says, is integrating behavioral health specific to the collaborative care model or directed integrated behavioral health more generally? I would say integrated behavioral health more generally, but in collaborative care, there is a reimbursement model that's being built in, but it's, you know, we'll work on the details of what that looks like depending on MDPCP versus primary care ahead, but it's not specific to collaborative care. Any questions?
So, Madam Secretary, I think there's a second question here in the chat. I'll just read it for you. It says, how will behavioral health ASO carve-out evolve to support MCOs, claims, and clinical information integration as part of behavioral health and PCP integration?
So we're working with Carolyn right now on that piece. We realize not only with the problems related to Optum as the ASO, but when Beacon was here the last time, that was something that was in place. And so we are actively working with Carolyn now to define what that looks like and what information and how it will be exchanged with the managed care organization so we can manage whole person care. So more to come on that. I don't have a specific detail of what that would look like since we're still working on those details with Carolyn now as part of the transition.
Okay, I don't see any other questions for the moment. We do have a hand up. Gene Ransom, welcome.
Hi, Secretary Herrera. Good to see you.
Hi, Gene.
Two questions kind of related to the questions that came up, and maybe you don't know the answer to the first one. The first one is, do you see them, because it sounds like there's going to be a transition period as we switch from what we have now to ahead. Do you see them having open enrollment for the Maryland primary care? Do you see that being extended for another year as we transition? Or what do you see happening, and how similar will the ahead version be to the Maryland primary care model that we have today?
So I would say yes to your first question, since we do have to have a targeted increase in participation, and there's no way to do that with under the current model. So I would say yes. And I'm not saying there's no way to do it, but it would, I don't know how you would just move lives to practices without opening it up for new practices to join. Chad is on the phone. So Chad, if you have a different opinion, please weigh in. And what was your second question?
Well, the second thing is it might be too early in the discussion, and this might be something you're talking about. How similar is what we're talking about in ahead to the current Maryland primary care program that we're running for Medicare?
So it's very similar. We haven't changed the terms. We've asked for some changes to the program based on the feedback that we've gotten from primary care providers, but we're still working through those details. I think the biggest thing back to the Medicaid first participation requirement, that's that second bullet there, is going to be the biggest change. So really understanding who our MD-PCP providers are, of those PCP providers, who is taking Medicaid today, and of the providers that are not seeing Medicaid beneficiaries, how can we support those practices during the transition year before 2027 to expand their footprint to be inclusive of Medicaid so they can stay in the program come 2027.
Yeah, and I would just say MedCai has supported having some type of primary care program in Medicaid for a long time. So if you would like us to be helpful with regards to that piece of it to make it happen or whatever needs to be done, we want to be helpful. And one other point I'd like to make on Medicaid, the awardee of the carve out put language in their bid allowing for value-based alignment. We could probably align certain elements of EQUIP to that as well. I know you talked about MDPCP, but maybe we can have a separate offline conversation about that. There are some challenges with that, but there's some things that could work. Particularly, I'm thinking about the behavioral health pieces that I think would work, but we can talk about that separately. And I'm happy to talk to Chad separately about how we can be helpful on the Medicaid piece.
Yeah, I mean, we just got the agreement and we're still going through some of the details and we have lots of questions. But yes, we'll be reaching out to you and to other stakeholders about what needs to happen and how do we go from where we are today to once we confirm the details of what CMMI is looking for to where we need to get to. And then happy to discuss primary care EQUIP and how to integrate this with everything else that's going on.
Yeah, primary care EQUIP, I don't think I think you have that under control. But
Okay.
I'm more thinking specifically about the new behavioral health bundles we created and that the Beacon contract had language that talked about having value-based care included in it. I don't want to get us into the weeds, so maybe I'll have a separate conversation with you or Ryan about it if that's okay.
Yeah, that would be great. Thanks.
Okay.
Dr. Scott, Secretary Scott, I know
Thank
you
you.
Hi. Just to add to something that Jean had mentioned, is also to, I don't want to say lower the bar, but to make adjustments for the eligibility criteria for practices. That's a huge consideration because there's a lot of practices that were locked out of participating in MDPCP. So hopefully that eligibility criteria can be, broadened so that everyone who wants to be part of this can be part of it.
Well, so the eligibility criteria for the next round, if it's not during the transition year, will be based on Medicaid. So it will be based on Medicaid. You won't be able to stay in MDPCP or come into MDPCP if you're not also taking Medicaid. So that second bullet is probably the most important thing to me on this slide, that Medicaid first participation will be a requirement. It says likely is a requirement likely by 2027. And we think they're giving us, the 2026 is the transition year, but we're still working out those terms.
That'd be great. Thank you.
Are there other questions for the Secretary? Okay, I think we can press ahead if that's okay with everyone.
Thank you.
Thanks, Secretary. Appreciate your comments and your help in setting this up in particular, and the work you've been doing. I also then we're going to move into speaking to the Medicaid. We're going to ask Dr. Lindsay, who's the Chief Medical Officer for the Maryland Department of Health, to give us a presentation and kind of take it further with the Medicaid part of this. So I'll turn it over to them. I don't see them, but
Good afternoon.
Priya.
As just stated, I'm Dr. Gingy Lindsay. I'm a board certified family physician, and as of March of this year, the Chief Medical Officer with the Maryland Department of Health. Very excited to be here with you today to discuss the evolution of primary care investment and infrastructure in Maryland. I am joined by a few team members from the Healthcare Financing and Medicaid Administration. We have Deputy Secretary Ryan Moran, our Deputy Medicaid Director, Tricia Roddy, and our Deputy Director for Innovation, Research, and Design, Laura Goodman. And I'll take about 10 minutes or so, maybe less, to review our plans for primary care and Medicaid under the AHEAD model. And we'll plan to take your questions at the end. And so I think we can advance a couple of slides. Next slide. And next slide. Okay, so I understand the slide here is a bit of preaching to the choir, but do think it's important to note up top the reason that we're here today. We understand that when we invest properly in primary care, that's going to drive our health system to deliver higher quality, more equitable, and less costly care. We have decades of research that demonstrate primary care physicians drive longer life expectancy in the communities they serve, help prevent hospitalizations, and decrease disparities in preventive services. And so we know that PCPs are at the core of achieving our triple aim. Next. And so Secretary Herrera-Scott just walked through broad vision for the department under the AHEAD model, and drilling that down a little bit more, how we're thinking about this driving through Medicaid. Our overall vision is making sure that we are advancing whole person care, establishing strong linkages across our healthcare continuum, and building a highly reliable program that's going to sustain advanced primary care as the foundation for Marylanders. Our goals under primary care AHEAD in Maryland, as the Secretary already shared with you, is to try to simplify some of this administrative burden for our primary care providers, making sure that we're continuing our Medicare investment while broadening the reach to Marylanders covered by Medicaid and commercial. And of course, the intent for many of these models and all of the work that we do at the Department of Health is to improve health outcomes for Marylanders. Next slide. Related to those vision and goals, we've built our initial concept on a few related design principles. First, we understand that we have years experience and established history of delivering advanced primary care through our Maryland Primary Care Program, or MCPCP. And so we want to make sure we're leveraging that success of MCPCP as we expand into Medicaid. Our initial model is going to start, we're planning to start with MDPC practices who have at least 250 patients attributed to any one of our Medicaid managed care organizations. And as the Secretary just discussed, as we progress, Medicaid will lead, meaning that you will be required to participate in Medicaid in order to participate in MDPCP. This also means that we'll be including pediatric practices in this model. I'm going to probably say the word simple quite a few times, but working to simplify participation in the model, striving to lower administrative burden, to hopefully attract in more providers, ensuring alignment of our quality measures across Medicaid, Medicare, and eventually commercial populations, streamlining reporting requirements, and providing clarity around the payment structures and performance expectations. And last but not least, we know the AHEAD model is going to be implemented over 9 years. So with this initial concept, we want to leave room for growth, both innovation in Maryland's healthcare landscape and in the alternative payment model. Next slide. And so you'll note here that we labeled the title 1.0 because, as I just stated, this serves as our starting point that we do expect to be developed. Under our initial concept, the Medicaid primary care APM will be built on 3 pillars. It's E&M increases, care management fees, and quality incentives. Next slide. Starting in July 2025, we plan to increase E&M rates for all PCPs serving Medicaid members in Maryland. So pending federal approval, we're targeting between 100 and 105% Medicare rate for all PCPs, meaning that you're not required to participate in the model to receive this benefit. And so our thought and our theory here is that we'll be supporting increasing investment into primary care practices who are serving our most vulnerable residents across the board. And so we also hope that this investment will help to provide some stability for our existing primary care workforce and make Maryland an attractive state for new PCPs. Next slide. For our practices who will be participating in the aligned advanced payment model, we will offer a flat care management fee on a per member per month basis. This PMPM will be based on all attributed members for that practice and will go to support establishing or expanding features of an advanced primary care practice. This includes providing care management or comprehensive care management for what we estimate will be anywhere between about a fifth to a third of members who would actually benefit from care management services. The department will develop guidance that will help define the high-risk population and establish minimum standards for care management supports. And we expect that this guidance will be applied across both the Medicare and Medicaid populations. Next slide. Lastly, with these investments in advanced primary care, we do expect to see a concomitant rise in the quality of care for our Medicaid members. And so we will establish performance-based payments for participating practices. Our goal is that the Medicaid, and this has already been stated, but reiterate, the Medicaid quality measures will align with MCPCP with focus on one of the things we know primary care does best, decreasing avoidable utilization of higher levels of care, i.e. making sure people cared for under this model are receiving the right care at the right time and the right place. The quality payments, like most programs, will be retrospective and will follow the culmination of a performance year. Next slide. I'm going to transition a bit from the core pillars of the model. I just want to make sure that you have some idea of where Medicaid members live and the general prevalence in your communities. And so this map is a very, very broad overview showing our Medicaid participants by county, where of course higher numbers of members are residing in those darker counties. Next slide. Here we can look at the population of Medicaid members distribution with a little bit more granularity. And so we're looking at MDPCP practices that will be eligible to participate in the initial APM. Those are noted by those purple pinkish dots. Those practices are overlaid by the number of Medicaid members by census tract. And so just looking at this or glancing over it, you can see for the most part, MDPCP practices who are initially eligible are fairly well aligned with those geographic areas where we have higher densities of residents who are insured by Medicaid. Next slide. Here we're looking at those practices who are currently in MDPCP who will not meet the initial attribution requirement, but given their location, may have opportunity to engage more Medicaid insured residents in their practices in the years to come. Next slide. And here, I'm not going to leave this up for too long, but you can see which Medicaid NCOs are participating in your county. Next slide. And so as we've stated a few times, what we just went over serves as our initial starting point. Moving forward, we're going to want to see expansion of participating PCPs and alignment with commercial payers. We also want to make sure we're driving innovation. There are greater adoption of those principles that were outlined by NACEM in terms of implementing high quality primary care, and that includes prospective hybrid payment approach, risk adjustment for medical and social complexity, and a greater alignment of incentives. And next slide. And so, as Secretary Herrera-Scott cautioned, a lot of things are kind of still in flux and we're still figuring out. But wanted to provide a very, very rough draft of how we envision the progression and relation of advanced primary care in Maryland under the AHEAD model, where today through 2026, we'll be finalizing and implementing the initial phase of the Medicaid APM while preparing for our next iteration. At that same time, we'll continue MDPCP and launch Equip PC, all leading to 2027, where we expect to have close alignment with Medicaid and MDPCP with that requirement for Medicaid to lead and supporting our Equip PC sites and transitioning to the Maryland AHEAD primary care model. And as Secretary already mentioned, these are not at all set in stone, and we do expect that some of this will shift as we discuss and plan with our partners at CMMI. And with that, I will ask my partners, Tricia and Laura, to join me, and we can take any questions at this time.
So thank you very much, Dr. Lindsay. While the group happened to be pondering any questions, I would invite Dr. Basinski, who is a primary care physician in Western Maryland, if he has some general comments to make regarding this presentation or the presentation from the Secretary.
No, thank you for the opportunity to share, David. Um, it's just really exciting to see this level of investment and attention in primary care. Um, I think alignment of Medicaid with the MD-PCP program will be an excellent addition and really will drive equity across the state. And if we can mobilize all the hundreds of primary care practices to be willing and excited participants in meeting the needs of Medicaid patients, I think it'll really move the needle measurably on health equity across our state. Um, I'll be interested to see how some of the behavioral health integration, payment structures and ways to make it easier and affordable for primary care practices, even small primary care practices, to try to integrate behavioral health. That's a challenge with so many behavioral health needs and what seems to be a perennial limited resources, but perhaps integrating with primary care, we can meet them more holistically in a team-based whole person approach. And I'd also be very interested to hear how it works out transitioning from MD-PCP to the AHEAD primary care model. And it would be advantageous to have some times of parallel participation um, with both programs so we can, sunset MD-PCP while still learning about the AHEAD primary care model, even if it's going to be similar. I really appreciate the thought and approach towards simple. That's a wonderful news to our ears, but I think some, parallel experience, while not completely being out of the current MD-PCP program, would be a nice, smooth, comfortable transition for us to learn the ropes as we, still have effective, funding models in the MD-PCP program. Probably the one thing that got my attention in the program was some of the specific funding goals for FQHCs to try to ensure their participation. And funding was a called out explicit goal. It cost all of us a lot to provide adequate care for the Medicaid population. I would just hope that uh, continued focus on not just improved but adequate funding for meeting the needs of the population that has high healthcare needs and some, as we all know, rather large SDOH contributions to not meeting their health goals. So I think the primary care doctors in the state are willing and ready to do it. We just need to literally be equipped for it, and any funding strategies to equip the small practices, the community practices. I think you can leverage a lot of willing physicians, especially the pediatric physicians, to really move the needle towards quality and equity for all Marylanders. So I'm just so excited to be in a state that's focusing on this and that's has targeted investment goals. So just thank you to everyone from the secretary on down and all the stakeholders here for looking at the needs of our patients and identifying primary care as the way to really move the needle on quality and health experience for all of our Marylanders. Thank you.
Dr. Lindsay, any comment, reaction here?
Catching me off guard. No, I just thank you. I think much of what was just mentioned is definitely points that we are working towards. Especially, I'm keen in on the point about making sure that the practices are willing and willing to do this, and just making sure that there are the tools and supports they need to be successful. And not just myself. I think I have other team members here. I'm not sure if anyone else wants to jump in.
And Dr. Lindsay, I think Alice has her hand up, so she may have a comment to expand more on your points that have been made by Dr. Brzezinski or yourself. Alice, are you able to talk? And you're on mute, Alice, if you're trying to speak. We heard you briefly. Alice, we can come back to you if you are able to work out the technical challenges. If you need, the team here can assist as well. Let's go to Dr. Dugarella next, and then we have a couple other hands raised.
Thank you, and thank you, Dr. Lindsay, for that presentation. I'm a family physician in Montgomery County, and I'm also president-elect of the Maryland Academy of Family Physicians. I had a question regarding the Medicaid requirement of having 250 Medicaid recipients. Is that per practice? The reason I ask that is I know there are some smaller practices that may not have 250 beneficiaries, Medicaid beneficiaries, and we just want to make sure that those practices that have smaller numbers than that are not excluded from this program.
Yeah, this is a bit of a struggle point. I think a few different priorities have to be balanced. And by all means, I have colleagues on the phone who are on the call, have been working on this for quite a few years to kind of figure out where can we start, and where can that make sense for the structure that we have here in Maryland with our managed care organizations, and again with the maturity that we've had with our Medicare model. And so as well as we all know, there's always going to be resource and budget limitations. And so where we do plan to start is with those practices that have 250 Medicaid members attributed to any one MCO. That is by no means where we plan to end, and we do want to, we will be building over the next few months to figure out what is the best way to be able to expand this program in the context of managed care organizations, to make sure we can include greater numbers of our primary care practices, and definitely how we can support our smaller practices. I'm not sure if Tricia or Laura, if you want to jump in there.
The only thing I would add is that's also the idea of giving across the board higher rates for E&M rates for primary care, that we're able to target a broader base of primary care with that initiative compared to the other components for phase one.
And this is Laura Herrera Scott, as opposed to Laura G, because Gingy, I think you're talking about Laura G, but I just want to add, we recognize that some practices may not have that, but we now have almost 1.7 million Medicaid beneficiaries, and we want them to reap the benefits of what Medicare beneficiaries are reaping under MCPCP. And so our goal is going to be to try and get as many Medicaid lives into an alternative payment model so they can have better care coordination, better assistance with health-related social needs. So, you heard Dr. Lindsay and Tricia, but certainly from my perspective, we want people and Medicaid beneficiaries to have the same improved health outcomes under this model as well.
Great, thank you for your comments. Yeah, I just wanted to make sure that there were practices that we could pull in as many practices as possible, and it wasn't going to have some practices just leave the MCPCP or AHEAD model altogether because they didn't have that patient population. Thank you.
So we have several more hands up. I'd like to sort of sequence if Dr. Cesari can speak, and then I'd like to invite Kathleen Logren after Dr. Cesari.
Thanks very much. Dr. Lindsay, we are so delighted with all the work that you and Dr. Herrera Scott and others are coming forward with to help primary care. Some of us have been involved in advanced primary care for a while and have been welcoming Medicaid beneficiaries, and without the advance payment, trying to do our best with them. And the numbers, as you guys know, are frequently limited if you are not proximate to neighborhoods with large numbers of Medicaid beneficiaries. And as you know, we have huge wastelands within the city of Baltimore with very limited primary care. So my question is, are you planning to include more incentives for people to move into those neighborhoods to provide care? I know we're excited about applying through Equip Primary Care, but I'm wondering if you have other ideas of ways to help people get started in underserved neighborhoods.
And so I think you hit the nail on the head there with Equip Primary Care, right? Looking at our investing in infrastructure for expanding that new access to primary care in areas that we have identified as being underserved. I think there are a few other thoughts and wishes that need to be fleshed out along the way. How do we increase workforce in general? How do we make sure that we're keeping the workforce that we have here today? We do hope some of that is through just making primary care a financially viable practice and profession for the state of Maryland. Some of that through this APM. And absolutely open to other ideas and concepts that we have with the Brain Trust on this call, and looking at the literature and best practices across the country. Again, I have other experts on the call with me. If any of my colleagues, Dr. Herrera-Scott or Chad, Tricia, want to jump in here, come to add.
Okay, that's great. Thank you, Dr. Chasari, for your question. Kathleen Logan, are you able to weigh in here?
I am. Thank you, David. It's good to see you and other members of the work group. First of all, thank you to Secretary Scott and her team for the tremendous effort and time and attention they're giving to this. I think that the MCOs are very supportive. The AHEAD model certainly builds on the principles that we believe managed care, Medicaid brings to the members within the program. Certain cornerstones, including the care management and addressing social determinants of health, are very important. And that's an area we can certainly expand and strengthen on. So we look forward to continuing to work with the Secretary and her team. We've been engaged, at least for the last year, on conversations around these concepts and these efforts. And I think to the extent that it is attracting more providers and strengthening the providers' participation so that they can provide additional support to the members is very important. And hopefully that is what AHEAD will bring to this Medicaid program and to the members in particular.
Thank you, Kathleen. Dr. Lindsay, any response at this point?
No, I think, as Kathleen kind of reiterates or supports much of what we said. I think there's lots of opportunities to align all of the various features that we have in our healthcare ecosystem, right, to streamline and make sure that we can put all these pieces together to really ensure that our residents are getting the care that they need.
Yeah, outstanding. So sequencing, Dr. Berenson, please weigh in here, and then after Dr. Berenson, I would like to invite Sally Alborn and then Shelby Boggs. So, Dr. Berenson.
Yeah, I guess one of my roles in this group is to be a curmudgeon or contrarian. I like most of what I heard, but I feel compelled to say that recently, like 2 months ago, with a co-author, I wrote a health affairs forefront piece after an extensive review of how preventive hospitalizations or ambulatory care sensitive hospitalizations became adopted as a quality measure, and found out that it has never been validated as a quality measure. And in fact, the only random trial in which they had one group which got regular care and another group that got intensive primary care, the group with intensive primary care had higher rates of hospitalization. One of the findings from the Medicare hospital readmission reduction program was at least a suggestion, not definitive, but a suggestion that patients with congestive heart failure did worse with lower hospitalization rates. It's relevant for some conditions, but it's been broadly adopted and for conditions for which theoretically and perhaps empirically it is not appropriate. So I'm happy to talk about preventive hospitalizations as a primary measure of quality.
Dr. Lindsay?
Do appreciate that. I think what we literature on even how do you define these quality measures and what's the kind of methodology we're applying will lead you down different roads. We are a bit excited to see some new information from an evaluation of MCPCP that's been done by our Hilltop Institute that is showing different, I think, from the reports that have been released in the past, is showing some greater gains there. Nothing that we can talk about in depth until that's publicly released. And so I would welcome a conversation around kind of fine-tuning and defining how we are going to be looking at quality. And I think that's going to cross over right across the state and across this entire model, as that's going to focus of the hospitals as well. I can stop rambling there. I'm not sure if anyone else wants to add in or jump in there.
This is Chad Furman. I can add Dr. Berenson. I think is an excellent point. You wrote it was an excellent article. Definitely saw that. From the MDPCP side, we don't use PQIs as a formal measurement. It's something we track and share with practices from a care management perspective, but we don't use it to adjust payment. And I think the thinking on the Medicaid side is that they would align with the MDPCP metrics. So as of now, we're not envisioning that we would have a ACSC or a PQI measure for actual primary measurement in the program.
Okay, thank you, Chad, Dr. Lindsay. Sequencing the group, so we'll go to Shelby Boggs and then Sally Alborn, and following, I would invite Dr. Barr to make a comment.
Hey, David and Shelby and others. Nice to hear you and see you guys. So first of all, David, let me say that I got left off the list by accident. So I had Alice's link. so, you know, I got out and came back in. So apologies for that. And apologies again as a result, because I may have missed the question I was so interested in, which was the 250 threshold. So I hope my statement isn't repetitive. I represent the Frederick County community and the CIN in Frederick. I'm the president of that. And although Frederick has a small Medicaid population in perspective of, you know, the city and the county of Baltimore, it is also the fastest growing in terms of Medicaid membership and population, and really fastly growing. I just want to recognize that in my CIN, we have two historical value-based care relationships with Medicaid MCOs where we feel very strongly that we've been successful. And we have several practices who probably will not meet that 250 threshold. So I would just ask that, you know, if that hasn't been brought up and considered, that we think about that maybe collectively, or if there's an exception process, because I would hate to exclude high-performing Medicaid practices who are also high-performing in MDPCP from this, simply because we're in a county that doesn't beg maybe 250 per a small practice.
Good point. Dr. Lindsay, your thoughts?
Yeah, I think just reiterating what we were discussing initially, that this 250 is to serve as our starting point. Our vision is that we are able to expand. I am aware there are other value-based programs going on in Medicaid, and I think as we are developing this next phase, or our next kind of iteration of the model, absolutely open and interested to learn about what some of the other strategies that have been working in the state that can help to inform how we are going to be able to pivot to expand to additional practices in the future.
Very good. Thank you very much. Sally Ann, comment?
Sally Ann, I think you're on mute.
Dr. Sharp, thank you. And Dr. Scott and her team, thank you very much for all the work that you've been doing on AHEAD and on other programs as well. I'm very excited about this opportunity. Maryland Community Health System, in conjunction with Priority Partners, has for the last, actually it's almost 10 years now, been working on developing our own sort of little informal ACO. We have 7 FQHCs with about 55 sites and about 79,000 Priority Partners members that we've been coordinating care for we've actually started very rudimentarily in 2014, and we've been constantly developing programs similar to the things that you're talking about in the AHEAD program, post-discharge follow-up programs, managing high-risk members, as well as coordinating access and care and social services for our other engaged members. So I'm very excited to see the depth of which you're pursuing this AHEAD program, and look forward to working with you and learning more, and hoping that we can elevate even what we've been doing in our own small way.
Dr. Lindsay?
Well, thank you. As I just stated earlier, I'm absolutely interested to understand, to continue to learn more about other features in our primary care ecosystem that can be applied and built upon as we progress under the AHEAD model.
I would be very happy to share. We've had a lot of learning opportunities, shall I say. And so we'd be happy to share our whole experience with you anytime.
I don't like to recreate wills, and I don't like to repeat mistakes that have already been made.
Great, thank you. Dr.
Thank you,
Barr.
Dave.
Oh, thank you, Sally. Dr. Barr?
Hi, everybody. Great presentation. Thanks for all the incredible work going on. I guess just a slightly different question than it's been asked. I'm really curious about the patient engagement strategies, outreach and engagement, get people more involved in their care. I think along the way, David, we've talked about sort of patient-reported outcomes, goal attainment scales. I'm wondering how those work into the models in the state.
I do want to talk a little bit about some of the experience with MCPCP. That's a lot of what we're building on, what they've tried and tested and succeeded in.
Yeah. Hey, Dr. Burr. As you know, in MDPCP, we've done some measurement around this using some of the standard instruments such as CAPS, and we've talked about potentially expanding that. CMS has been sort of tied to CAPS for many years, but I think there's openness now. You're seeing in some of the other models like Making Care Primary to using things such as the PCPCM, which is more about experience and it's specific to primary care. So I think that's something to consider in the future. I would say is, from a measurement perspective, we haven't gotten that far in terms of what it would look like. Certainly in terms of patient engagement, the key thing to that is really access both to the traditional and the alternative sense. So I think we're going to want to drive that in this program. And addressing social needs and being focused on health equity, I think will also improve that. But I think we have a fair amount of planning to do that. We're going to try to leverage your expertise and others in this group to think through that.
That's great. Thanks, Chad. Thank you, Dr. Lindsay.
Thank you, Dr. Barr. Dr. Riedman, and thoughts here?
Yeah, actually, thanks, David. I just really want to echo what's been said about the 250 patients and the Medicare population. That I would hate to see that and I'll make some other comments about the MDPCP program, but I think it's extremely beneficial, especially for our group. And I would hate to see a group with a high Medicare population and a low area of Medicaid not be able to participate with the MDPCP program and the advantages of that what it brings to our practices because they don't have enough Medicaid patients. And one of the things in the past, I know for different insurers and all, we've been able to participate with plans, but it's been more if we're open to some of those plans, accepting new patients, but not necessarily a minimum of patients. So something to think about. But that I echo the thoughts about the concerns of the practice not being able to participate with MDPCP and the advantages I think that it brings.
Okay. Thank you, Dr. Riedman. So there's one comment. I'll just read it. I don't know if Dr. Tsari, you wish to make the comment yourself.
Well, it was just a follow-up to the comment about the relationship between advanced primary care accountable sort of ownership along with the patient and the reduction in utilization and health outcomes. I think you know, there are data out there in both directions, and it would be a great opportunity for us as we really get into this to study it. I know we're very, as a state in Maryland, we underutilize palliative medicine and hospice. And there is some evidence that patients who are not going to, who are deemed to no longer have a good acute care strategy when they choose hospice, there's some evidence that they live longer by a few days.
Good point. Dr. Lindsay?
Yeah, I think absolutely. I think there's the literature and the research on what works in healthcare continues to evolve. No one's figured it out yet, but I think, you know, we have made a lot of good progress here in Maryland, and hopefully that keeps pushing forward under this model. And absolutely looking forward to additional evaluations and studies of what we're doing, and is it helping, and based on those results, how should we be iterating and changing and shifting to make sure we're meeting our population needs and maximizing our potential as a state to have a healthy population.
David, this is Laura. I just want to add, so John, you know, I would say in the continuum of care that I showed you, you know, certainly palliative care and hospice care and just end of life care, end of life planning in general is certainly on the table. We're talking about a primary care right now, but there's other work underway to address that part of the continuum that we just haven't brought up here today.
Yes, thank you, Secretary. I was really just reacting to the concern about not much evidence about the reduction in unnecessary utilization having a positive health outcome. I think that there's some evidence out there that could lead you in either direction, and it's an opportunity to better study the whole issue. That really was where I was going with my comment, but thank you.
Thank you, Dr. Chisari. Dr. Okiki, question.
Yeah, thank you. The question I had was, knowing that the secretary had mentioned in some meetings past that she was very interested in having pediatrics and maternal health be very involved in primary care. So just wondering if the criteria for, you know, eligibility being the 250 Medicaid beneficiaries is also inclusive of that, and if there's any call out making sure that those populations are represented.
So I'll start, Gingy. So pediatrics, yes, I think we still have to figure out the definition of primary care. So the definition of primary care, or who is a primary care provider, from the primary care investment work group differs from the definition in AHEAD. So I think we have more work to do on who is a primary care provider.
Thank you, Secretary Scott and Dr. Okiki. There is a question or comment from Dr. Marsteller. Dr. Marsteller, please.
Yeah, I was just wondering whether there are limitations sort of to marketing to Medicaid beneficiaries if practices were interested in inviting more Medicaid beneficiaries to join their practices, for example. That's one question. Another one is around making sure that practices that may not have served this population extensively before understand you know, unique aspects of the population and address them, you know, appropriately. How might they learn how to provide best evidence care for these populations? So
I'm going to invite my colleague Laura for that first part, and then maybe Chad can talk a little bit more about kind of the possible supports with the PMO. I think the answer is, I think there's no prohibitions on practices marketing. I know there are different prohibitions from the CO perspective. I don't know if you want to elaborate on that.
Absolutely. Thank you for the question. And I actually might dodge this one and see if Trisha or maybe even Kathleen Lochran have thoughts on how this works in terms of primary care practices, conducting marketing activities. That's just enough outside of my wheelhouse that I wouldn't want to commit to a response in front of this group.
Understood. Anyone able to weigh in?
So I think Dr. Lindsay answered it. I mean, there's a lot of there's prohibitions around steerage within MCOs. I think you know, physicians and practices can obviously do outreach to enrollees, but I think the better question is, are you contracting with our managed care organizations? Kathleen Lochran's on the call. You know, all of our Medicaid managed care enrollees are assigned to a primary care doctor, and they have a primary medical home. And so that's the goal, is to make sure that you're getting those attributed members. And there might be ways that you can work with your contracted MCOs to make sure that you're getting a larger number of individuals assigned to you. And so I don't know if one of the other MCOs wants to address that, of how you work with your primary care providers and how you grow their practices.
So, Kathleen, any response here is different or in support of?
So I think Trisha's right. I mean, a goal for us, and I think every MCO, is to ensure that members are aligned with a PCP, but particularly with a PCP that they are comfortable with and that they are going to use regularly and go to when they are in need of care. And sometimes that is more difficult depending upon an individual's situation, particularly if they are homeless. And it's particularly necessary if it's an individual with chronic condition. So I think each of the MCOs have efforts that they put forth in order to make sure that the members are not only being assigned or selecting a PCP, but then making use of that PCP to access care.
Very good, thank you. And so there's Dr. Brzezinski has a question, and then just sequencing Debbie Kuchka-Craig for a comment following Dr. Brzezinski.
Hi, thank you. Just a quick comment about the you know, Medicaid base number for participation in the you know, future programs. I know, and maybe this is getting the weeds a little bit, but when Care First came out with their patient-centered medical home model, they needed certain number of lives, you know, to make it work actuarially. And they created virtual groups. I see Dr. Lindsay shaking her head. Yes. So perhaps I'm just speaking to the choir here, but that in my small town was very effective. It aligned several small practices in our community and allowed us to participate in a program that was very advantageous for us for the years we had wins. And otherwise, we'd never be able to participate. And it was some of our earliest experiences with PCMH care. And you know, it really was aligned with the standards of advanced primary care. So perhaps there could be something like that for interested groups to create virtual groups within a community, you know, not disparate areas across the state, but, you know, several groups together could apply or such. That's maybe a virtual group or something for the purpose of this program to allow participation.
Interesting. Dr. Lindsay, your thoughts?
Yeah, no, I know exactly where Dr. Brzezinski is going with that. I think that is one of the options we are looking at, or what level of feasibility is to drill down to lower numbers. Again, our full intent is to make sure that this program can reach as many lives in Maryland as possible. And so for any of the great ideas that have run through your minds, we are happy to receive those as we're building out the next phase.
And I echo comments of other commenters that, you know, should we lose MDPCP programs because they don't have meet a Medicaid threshold in the future, I think that'd be a tremendous loss. So I think really the goal would be to see how we could, you know, maintain participation and, you know, increase participation. And appreciate all the efforts you all are putting into it and the opportunity to have some really novel and advanced ways of taking care of some of the patients with the highest needs in our communities.
Thank you, Dr. Brzezinski and Dr. Lindsay. Debbie Kuchka-Craig.
Good afternoon, everybody. Good to see so many of my colleagues from the Advisory Council. This is very exciting. I can't say that I understand how we maximize the lessons learned. People have commented on the Medicaid MCO value-based programs that are out there. And certainly we have so many lessons learned with MDPCP and commercial value-based. I guess the challenge is to make sure that we're moving toward alignment, but also capitalizing on the lessons learned with very specific experiences that we've had. It's a little confusing to me still how we avoid duplication of effort that the Medicaid MCOs have in place right now with care management and the like, how that fits into the program. But I'm sure that there are lots of forums where the Medicaid plans are at the table and trying to make sure that we understand who's going to do what and how it all fits together.
Dr.
If
Yeah, this is Kathleen.
Coordination, yeah.
Okay.
Yeah, so thanks, Deborah. It's Kathleen Lochran again with WellPoint. So, as an MCO that has had value-based plans for quite some time now and has had primary care programs in the past, we are sensitive, as some of our competitors are, to the duplication of some of the efforts around what we currently do and what may be looked at for the future. But, MDH has really been great in working with us, and we view this effort around the AHEAD model as a partnership. It's a tremendous opportunity for us and for the state to better serve those lives that are in the Medicaid program. And we continue to have conversations about what our current capabilities are and how we can strengthen and expand those capabilities without necessarily tearing down what we currently have, right? Particularly as it applies to quality and to our provider participation. And hopefully some of what we're building now will allow us to incent members who historically don't use their providers, right, to engage more fully and come into this program and get the services that they need.
And
if I could just follow up on that, there was a comment earlier about engagement and I know a lot of the MCOs have clear assignment so the primary care practices know who is supposed to be seeing them, but it's a team effort for that outreach to ensure that they are engaged, because just because they're assigned to the practice doesn't mean they're receiving the care, as we all know. So thank you for that.
That's right. That's right. And I mean, your history with this program and your knowledge is valuable and it's spot on. And I think that's an area that maybe this AHEAD program can help with as well, just to make sure that this team approach, we don't want the providers left out there with just a list of who should be coming into the practice, but we want to help and engage in getting those members into the practice for the care that they need.
Thank you, Kathleen and Debbie Kuchka-Craig. So a couple hands and comments. Before we get to Dr. Bernstein, I think Dr. Brzezinski had a follow-up, and then perhaps after Dr. Bernstein, Stephanie Scharf could talk a little bit about what her thoughts are.
Yes.
So, Brzezinski.
Yeah, thank you, thank you, David. Based on my practice has participated in ACOs ever since the ACA allowed them, and our first one was the MedCai ACO. And one of the hard lessons learned there was in an effort to be cost effective organizationally, we had centralized care management, and that was a pretty big fail. I hope Jean's not here and giving me dirty looks. But it was a hard lesson learned, and most recently participating in MDPCP, and I'm part of the Privia Medical Group, and we have an embedded care manager, somebody who comes to our office once a week, who knows our community, knows our patients. It is night and day the engagement of the patients with somebody who's local and knows the community and doesn't say foolish things like take the bus to your appointment when there is no bus service, et cetera, et cetera. So for those who are the representatives of our Medicaid MCOs, if you all are going to have opportunity to steer how this program goes, I can't plead enough for local, embedded in the practices, care managers. There's many strategies to make these care managers feel like they're part and parcel of us. Thanks, Gene. But the patient needs to feel like they're being called by their doctor, by their practice. And that builds trust, that breaks down those barriers of a phone number they don't recognize that they never answer because it's from some organization in Baltimore and I live in Garrett County or vice versa. So I just plead with you all to figure out ways to get care management into our practice for this program to support care management that's embedded with real people in our practices representing their doctors. And that breaks down so many barriers that that I think keep Medicaid patients from engaging their providers and utilizing us. So thank you for the platform to discuss this. Thank you for hearing me out. Appreciate y'all.
Hey, David.
Yes.
I'd like to chime in on that. Actually, that echoes really the thoughts that I wanted to bring up, and I might as well bring them up now. But the total cost of care, we've done a phenomenal job. I think our practice around the state to do that, but it is difficult because there's still a lot of things that in the MTPC program and in healthcare that we can control primary care to some degree, but there's a lot of costs that we have no control over. And some program that would define some of those costs and eliminate some of those costs that we don't have control over from our total cost would be helpful. But the one thing in the 43 years that I've been doing this, nothing has improved my quality of practice and my patient's quality than exactly what was just brought up. The fact that we have in our offices, we've used the additional funds to hire a care manager, case manager, social worker embedded in all our offices. We have a PharmD that we actually now have working full time for us. And those things have improved the quality for my patients tremendously. And like was just brought up, that I can walk across the hall, or when the patient's here, they walk across the hall and see my patients. Those programs have been phenomenal. And I would strongly echo the fact that if we do nothing else, any of these programs that we do, having the primary care physicians have the ability and the funding to have that embedded in their office is tremendous. And it's really helped our patients tremendously. I can't tell you how many times that my patients benefited from that. So those echo my thoughts I wanted to bring up before, but or later, but this is a perfect time for it. And I appreciate those comments, but I think those are, I feel very strongly about those. And again, thank the program for all it's done for that. So
Yeah.
I'll turn it back over to you, David.
Thank you, Dr. Reedman. Dr. Lindsay?
I think they're all definitely excellent points. And I think going back to a little bit of the previous conversation, we absolutely want to do our part in designing this model to decrease some of that fragmentation of care within our ecosystem, right? We know there is a role for an MCO, we know there's a role for a PCP, and we know that the needs of one community might have differing needs from another. And so all of those features we do hope to support as we continue to build and evolve in the model.
Thank you, Dr. Lindsay. So Dr. Bernstein and then Stephanie Scharf, and we have a few other hands raised, so we'll be going in sequence. Dr. Bernstein.
Thank you. Thank you for the opportunity. And I add my appreciation to the groups that have really worked on this. Is very exciting. And I would also add that the extension of the program to the pediatric age range and in Medicaid really is the continuation of this enhancing the health of all Marylanders, not just Medicare age primary care patients. So that's really important and encouraging. And I would hope too, to the extent that our goals are alignment with commercial payers, that similarly reaching down to all age range and forms of primary care will follow. The comment that I made, just another element of the concern about the thresholds for Medicaid provider participation in these programs. The concerning thing is that, if I understand correctly, we're talking about a 250 beneficiary threshold for a single MCO, which seems counterproductive to expanding access by encouraging multiple, participation with multiple MCOs within a, a practice or provider. And one would hope that part of the outcome of all of this is the alignment of quality measures and methods and support across the MCOs so that multiple participation is practical, and that should be encouraged rather than focusing on a just one MCO or a small number of MCOs.
Thank you, Dr. Bernstein, for the comments. So I am also mindful of time, so let me see if I can get through perhaps 3 more questions, and then if we don't get to your questions or comments, if you can put them in the chat, we'll be sure to follow up appropriately. I wanted to turn to Stephanie Scharf, and then we'll go Sally Ann, Nora, and Dr. Khanna, and then and Dr. O'Keefe, and then we'll conclude. Stephanie. Okay, I'm not sure if there may be some technical challenges, so Stephanie, we can come back to you. Dr. Khanna, let's invite you to say a few words, and then we'll get to Sally Ann, Nora, and Dr. O'Keefe.
Thank you, David. I apologize for being late. I just wanted to say that our practice is based in West Baltimore, and we see a lot of Medicaid patients. And over the last 30-some years, 34 years that I've been in this practice, the normal way we get Medicaid patients is a list. We get the list, and then we hear from the MCO, usually when the metrics are due, or when there's a default on some metric or the other. And I think as we move forward and we're looking at the AHEAD model, I really think that the way to manage patients who are low income, based in West Baltimore, who don't have public transportation, is to think about all of those social determinants and to support practices in managing these patients, which includes not only embedded care management, but also transportation. Transportation is one of the major reasons why patients don't come to the office, don't get there on time. And many times if they show up late, they end up not getting seen because the provider can't accommodate them or whatever the reason is. So I'd really like to make a pitch for a lot closer collaboration by all these MCOs and the practice. And I think if we are able to establish a communication channel, not only with the patient, but also with the insurer, that we will only come out the stronger at the other end. I just want to make that point.
Thank you, Dr. Khanna, for that comment. Sally Ann?
I just want to make 2 quick comments. One, I just want to reinforce Dr. Shazari and Ken Brzezinski's and Dr. Ribman's comments about embedding care management and care coordination in the practices. We've tried it both ways. The first by having external care managers bombed, to be polite about it. So we moved to the embedded model, and that's what we use now. And it's much more successful. The other comment I want to make is I think as we work with the Medicaid population into AHEAD, we need to think about strategies to engage a fairly significant number of the Medicaid population that's attributed to the MCOs, all of them, who are unengaged with their care, and factor that into both the quality metrics and our strategies for our outcomes. Their lack of engagement impacts a lot of things, access, as well as our quality performance.
I would do just want to always add there on that item of engagement, we have to make sure we're building a system that people want to engage with, right? And so I think that's part of the issue also.
Absolutely.
Thank you, Sally Ann. Nora.
Sorry, that took a while.
So, hi everybody. I'm Nora Hoban representing the 16 FQHCs in Maryland. And I just want to say I'm probably one of the only ones not too stressed out about getting to that 250 number for each of the practices. What I would share, I think, is that FQHCs are unique. As most of you know, we have a lot of services under one roof, including behavioral health, dental, and those sorts of things. There's also a lot of emphasis on how you talk to patients. A lot of cultural competency training, a lot of trauma-informed care. So I think there's probably ways to share across with each other and things that maybe FQHC may be able to share with other colleagues. I would just point out too, we have a lot of experience going back to the MD-PCP, where we can learn from many FQHCs what investments they chose to make, including social determinants of health, including care coordinators. And it's almost like we have a natural experiment already happening, and figuring out what made the most sense for some of those practices, and where did we already see some successes with our Medicare beneficiaries, and how do we apply that going forward with Medicaid. So thank you so much to everybody on the state for all the good work you're doing, and we just appreciate seeing more resources down the line. So thank you so much.
Thank you, Nora. And we'll turn to Dr. Okiki for the last comment on this particular topic area. Dr. Okiki.
Thank you. The last comment I wanted to make was just based on the experience of what we've done with the different populations, Medicare, Medicaid, and others. I think we want to emphasize not only having embedded care management and care coordination, but also community-based care management and care coordination when you're thinking of the Medicaid population. So successes that we've seen in the Medicare population to know what transfers and what doesn't necessarily do, and making sure that we just add on to the success that we're seeing now, that we can have a very holistic approach to making sure that we address the social determinants of health and individual health social needs as well to see the outcomes that we're looking for.
Thank you, Dr. Okiki. So let me turn this back to Dr. Reedman for introductions to the next segment of the agenda.
Great. Thanks. I had to unmute myself because I think Melanie muted me. Again, I think all these comments are great. I really appreciate, as everyone has said, the work that everyone is putting into this in the state and what they're doing, and which brings us kind of the MD-PCP program. And as an early participant for our group, I have to say it's really been an excellent experience. There certainly are growth issues. I think that I mentioned the cost of care and the responsibility for that, but some of the programs like the embedded care workers and the extra funds have been extremely helpful. So I'm going to turn over to Chad Perman to go ahead and give an overview of it. Before he does that, Chad, I have actually a question, I think, for you or maybe the secretary, but some of these meetings start to run together. But we get heart payments, as everyone's aware of, and they've been very helpful, but some of our patients just don't need them. But we have other patients that really could benefit from them. And I think at one meeting, it was mentioned that there was some talk about making the heart payments, that we could use them for any Medicare patient. And I don't know if that was through the MDPC program or the HEAD program. So as you go through your presentation, Chad, I'll ask you that question and or the secretary if my memory is correct on that, and if that's a possibility, because I think there are definitely some of our patients we'd be able to use those funds for, and others that really don't need them that are in the program. So I'll turn it over to Chad, and we'll go from there.
Yeah, thanks, Dr. Reedman, and an excellent segue to my one slide that I have. So I just have a few updates because I know we have a few more things to get to before the stop at 6. So if we can go, let's see, 1 or 2 slides forward to my slide. One more. Okay, great. So to that point, Dr. Reedman, let me provide a few updates, including around heart. So as you guys have heard, we have ongoing AHEAD model negotiations right now. The MD-PCP transition timeline to AHEAD is what we're trying to determine right now. We are in discussion about some policy changes for 2026 MD-PCP to improve how the program works, and also to create a glide path to MD-PCP under the AHEAD model. So CMMI has agreed in principle, only in principle at this point, but to two changes. One is expanding heart payment usage, the usage of those dollars, as you're talking about, Dr. Riedman, to all MDPCP beneficiaries. We have to work out exactly how that would get put in place for policy, and it will take some work with our CMMI colleagues, but they seem open to moving forward on doing that, not for 2025, but for 2026, as a way that we move towards an integrated program under AHEAD. The other thing that we're working through with them is continuing the availability of Track 2. Currently, Track 2 is set to sunset December 2025. So we are working on continuing Track 2 as well as then revising the associated transition requirements around that. More to come on this as we talk through it and exactly how that could get put in place, but we're cautiously optimistic that we can make those changes for 2026, which will help us as we move into the Medicaid first requirements and MDPCP continuation in 2027. So while we figure out potential changes for 2026, we also want to ensure that we have continued participation in MDPCP while we're ramping up for the Medicaid APM. So for 2025, there will be no policy changes for 2025. In prep for 2025 this fall, practices and CTOs, as I think many of you know, will go through the usual participation agreement process and the track transition processes. And then once we have more clarity on how MDPCP will fit under AHEAD, which we will know in the coming months, we will be communicating with this group, but also importantly with participants in the program this fall to reassure them about the continuation of MDPCP and how we envision and our understanding this is going to unfold. The other thing I wanted to bring up everyone up to speed on is the EQIP PC, or the EQIP Primary Care Pilot Program. I think many of you are aware of it, but some of you may not be. This new opportunity, the state is looking to provide seed funding for a handful of new primary care practices in underserved zip codes around the state. So the idea is to provide new access, and the key word is new access to primary care in these zip codes. We anticipate the program will run 2 to 3 years to allow practices to establish themselves in preparation, right? This is a pipeline program in preparation for joining both the Medicaid APM and MDPCP. The PMO is going to be involved in this with the Secretary's leadership, and Dr. Lindsay's leadership will be leading the management of this program in close partnership with our colleagues at HSCRC. This program will be run under sort of as an offshoot to the EQIP program, which is the episode quality improvement program for specialists, which has bundles in it, and which HSCRC oversees. So it will be a state-run program under the authority of the model. And we put out an RFA last month. The deadline is coming up of August 30th, and we anticipate making selections probably by October with a start date of January 2025. So those are the updates I wanted to share with everybody, both on MDPCP and EQIP, and how that EQIP fits into sort of the transition into our advanced primary care programs and how we see this sort of spectrum of primary care programs developing over the next few years. Any questions or comments?
Thank you, Chad. Gene, question, comment?
Yeah, I just want to say if anybody needs any of the materials to look at the EQIP primary care thing, you can email me. I'm happy to share it. It's on the CRIS website, though, so it's really easy to get to. And the other thing that's on the CRIS website is the PMO and the HSCRC have been updating a FQA of questions people have asked. So I would just suggest that once you look at it, you might want to look at that document because I think they've done a good job answering some of the confusion. The second thing I want to, there you go, look at Chad, he put it in there for me. Anyway, the second thing I wanted to bring up is traditional EQIP, which is the committee that is a lot of you probably think of as being more of a specialty program, purposely added some bundles that might be worth considering for primary care. The sign up for traditional EQIP is until also August 30th. I would particularly call attention to the behavioral health bundles for those of you who have embedded social workers or other practitioners who bill Medicare. it's a really good opportunity to get into that program and then get them into an advanced payment model. MedChi is happy to help. We actually have I chair the committee. The committee is run for that program by the EQUIP program is run by the HSCRC. But I would just encourage you to at least look at the 2 behavioral health bundles that were added for Medicare. And if you need help with that, we have videos and information on that. And I'll put information on that program as well. And it's a really good way to get your practitioners, whether they be, most of you probably don't have psychiatrists, obviously, but there are other non-physician practitioners who could be eligible for EQUIP and for an advanced payment bonus in those bundles. And we're happy to help you with sign up. Okay.
Thank you, Gene, for that comment. Any other questions or comments at this point? And Dr. Riemann, did Chad get to the answer to all the questions you had, or was there other lingering one?
I don't see any other questions. Are you asking me or are you asking Chad?
Yeah, I thought you had a couple of them. I know you were able to get one of them out.
No. I think I made my comments with my major one was about the benefits of the embedded care workers and all that. So I think I got my questions in my comments earlier.
Okay. All right, very good. So with that, Chad, thank you for the excellent update on the MDPCP. So we'll turn back to the agenda. Dr. Riedman, do you want to take us forward?
Yeah, actually, I think it's you and Kenneth are going to do talk about the primary care investment work group and the head definitions and all, and that's actually our last agenda item, and we actually may make it through an agenda for one of our meetings, which would be nice. So I'll turn it back over to you.
Outstanding. So Matt, can you bring up the presentation, please? And as Dr. Riedman mentioned, my colleague, Kenneth Yates Trotman, will be joining me for somewhat of a collaborative approach to the discussion. So we'll pause momentarily while Mac brings up the slides. Mac, or okay, go. Okay, so I'll kick it off. The discussion, as Dr. Riedman noted, last item on the agenda, so we don't want to stand in front of folks getting out the door at 6, so we'll be very efficient in our time. We are going to talk a little bit about the HEAD model as a comparison to the multi-state definition that was developed by the Primary Care Investment Work Group last year in 2023. We'll also present a few data slides on the comparison of the investments between the different payers, Medicare Advantage, Medicare fee-for-service, and private payers. We'll look at them as a totality, and then we have a few slides to look at them in terms of distribution across the different regions of the state. And at the end, we're happy to take any questions. So next slide, please. So let's just give everyone a quick background of how we got to where we are. Most of you will probably recall that in 2022, the legislature passed Senate Bill 734 on the Maryland Healthcare Commission Primary Care Report and Work Group. And there are really two major components. One was to convene a work group and develop an analysis plan so that could guide the work of the primary care investment work group into the future. And the group met throughout 2023, first few quarters quite ambitiously. In October, there was a plan draft developed and presented to the Maryland Healthcare Commission commissioners for approval. The plan was approved and submitted onward. And we'll talk a little bit about the plan in a moment. The other arm, if you will, of the Senate Bill 734 is to annually report on ways to improve quality and access of primary care services, with a special attention to increasing healthcare equity, reducing healthcare disparities, and avoiding increased costs to patients and the healthcare system based on the plan beginning in December 2024. That is when the first annual report is due. which this year it's a sort of a getting started year. And so looking at some data, we have enough that can at least put a good peg in the board to let everyone know where we are. And I think we'll show you some of that today, and we're planning to include that more of detail in the actual report. Next slide, please. So this is the plan that was submitted. The plan, as I noted, is sort of a strategic planning framework that is intended to evolve over time to keep pace with the changes. The idea is to re-envision how investments in primary care will help address longstanding challenges that fall heavily on the disadvantaged communities. We've heard a good bit from the attendees and some of our presenters around these types of challenges. And the plan was developed with a concept in mind of looking at domain specific. And you'll see in the next couple of slides that approach is kind of percolated through the comparison with the AHEAD model definition. There's expectations that the plan will continue to evolve and domains will be added as we move forward. Next slide, please. So there's a lot on this slide. So I'm going to try to summarize it a bit rather than necessarily read it line for line. But many of you have seen something similar to this. And if you start at the top and you sort of say, this is the construct, if you will, for the definition that was proposed by the work group last year. And what it is essentially they settled on the multi-state definition, which is used by, I think, nearly 20 states at this stage. So as much as the work group pondered on what could be different externalities, they ultimately settled on a definition that very much paralleled what's happening across the nation and emerging. Lo and behold, it wasn't too long after the work group completed its work that the proposed notice of funding opportunity was released by CMMI. And so we did some quick comparisons. First, it was a little bit of back of the envelope and then a bit more granular. And just to summarize, there's differences in the definition between the multi-state and the AHEAD model. And by and large, the definition in the AHEAD model is a somewhat broader. So it includes 30 psychiatry and obstetric and gynecology specialists into the definition that aren't included in the multi-state primary care investment work group definition. Another difference is in terms of provider taxonomy codes, which are used to calculate the investment. While there are specifics in the PCIW for short definition, the codes, the CPT codes and HCPCS codes identified by CMMI that are included in the AHEAD model align with the Medicare shared savings programs. And there's a little bit of difference around how nurse midwives and behavioral health providers are included into the definition. As long as they're billed under the taxonomy code of the primary care provider, they are included. And for comparison purposes, the FQHCs and or rural healthcare clinics in the AHEAD model, they're counted as primary care regardless of the provider specialty code. So you begin to see that while there are some alignment, there are some clear differences. And the investment that the PCIW recommended was a 10% increase over spending by 2030 and would have relative improvement goals of about 1% annually and adjusted periodically to make sure that the payers are achieving the aim. In comparison to the AHEAD model, increased investments in primary care are viewed as a proportion of total cost of care for the Medicare fee-for-services and across all payers. CMS anticipates the primary care intended target for Medicare will be between 6 and 7% of Medicare total cost of care. The strategies, there are some similarities, but I think what I would note here is how the spending per member per month as a percent of total medical expenses filters on a different set of providers somewhat, and it doesn't include pharmacy spending, rebates, dental, and other supplemental expenditures in the calculation. So there's a little difference there. States with accountable care organizations and meeting the annual improvement targets throughout the duration of the implementation period for primary care investments are considered into the AHEAD definition. And lastly, I would just note that there are 39 taxonomy codes used as the filter, if you will, for primary care providers. And in the AHEAD model, they do not use taxonomy codes. The model is built on specialty codes, which are broader than taxonomy codes. And by way of example, these 16 specialty codes yield 57 taxonomy codes and roughly 181 billing codes when looked at CPT and HCPCS are included in the definition. By way of comparison, of the 113 codes, there are roughly 344 billing codes included in the based on the taxonomies of the PCIW definition. So there are some discrepancies. I guess probably one way to think of it as we move on to the next slide is that the specialty codes, there are more providers included into the mix, and that creates different ranges of investment when you do the calculation, which you will see on this slide. So on the next 3 slides, we'll see at a summary level of these investments. And here you have the total spending as a percent for the primary care investment work group compared to AHEAD, and then the difference. And the difference you'll probably note throughout is the variation tends to be between about 1.5 and 2.4%. So it's very close and consistent, but the definition is driving the variation because the AHEAD model essentially just captures the net is wider with a broader definition. But you do get a glimpse of where the spending is in the state so far, both at the highest level, if you will, as a percent of total medical, and then based upon per member per month spending. Next slide, please. So that was a glimpse of the private payer. Let's sort of show you on the Medicare Advantage side of the equation. And here again, if you look across, you see the investments, but the difference underscores essentially the notion of what we were just talking about a moment ago. So you can see the differences here. And let's go on to look at the Medicare fee-for-service. Next slide, please. And here again, is somewhat consistent, nothing surprising in terms of the variation and in terms of regarding the investment, still hovering around the same percentage. And it's fairly clear what the drivers are at this point by and large. So let's travel on and with the presentation. I'm also trying to be mindful of time. Mac, next slide, please. So at this stage, I'll invite my colleague, Kenneth Yates-Trotman, to talk a little bit about the next few slides. Kenneth.
You're on mute, Ken.
Sorry. Thank you, David. So with this slide, we're looking at the private care investment by region, and we have it divided into 4 regions, Baltimore Metro, Eastern and Southern Maryland, DC, and the Western Maryland. And then on the top, we see we look at it by payer, from Aetna through CareFirst, United Healthcare, Cigna, and Kaiser. And then the other category includes TPAs, excluding the TPAs that is associated with United Healthcare and CareFirst. And we also, this section also includes the State Farm company, which just provides health insurance to their employees. The takeaway here is that we see that in the Western Maryland, we see it mostly have the highest primary care as a percentage of total medical at about about 5.9% for United Healthcare, but Kaiser seems to be the highest investment, looking at the primary care investment across all regions. Looking at the head model, we see that the primary care investment is consistently lower than the head model, based on some of the things that David talked about in the prior slides, because of the head model has more wider or broader codes than the primary care investment. Next slide, please. So here we look at the Medicare fee-for-service, same thing by regions. And we see here that, and for this one, we have data through 2022. And we see that in this segment, we see that the Baltimore City seems to be the lowest primary care investment, across when compared to the other three regions. Less primary care is actually invested here in Baltimore City, and that is consistent with the head model as well. Of course, the primary care investment work group method is lower than the head model. Next slide, please. And then we look at Medicare Advantage. So we're looking at this for 2023, and we have to note here that for 2023, this data is 9 months of information, as that is the data that we have available so far for 2023 with 3 months of runoff. So and the other slides we had was 12 months, but for 2023 had 9 months of information. That is 3/4 of the year, and looking at this, we should not expect the results to change that much when we have 12 months with 3 months of runoff. The takeaway here again is that Kaiser it seems to be the higher investment on the primary care work group method, and that's also is consistent with the head model as well. And that's followed by Humana, seems to be the other highest investment, as far as primary care is concerned, and that is consistent with the head model as well. We see that the head model is consistently higher than the primary care investment, based on those definitions that they were talked about. Next slide, please. So the other 4 slides that follow, we attempt to have an explanation as to why the primary care investment work group is lower than the head model. And for this one, we look at the private payer for 2022 data. Next slide, please. So first, we try to find out, well, why is the investment from a PMPM basis is actually less under the primary care investment work group and compared to the head model? Well, first, what we want to do is to compare the same specialties that are common between the head model and the primary care investment. And we see here that at the primary care investment is at $25.74. But at the head model, we see even before we bring in the other specialties, we see it is already higher by $2.39, or about 8.5% lower from the primary care investment. So we see that off the bat for like specialties, the primary care investment is lower than the head model. So it's really very hard to catch up, because when we include those other specialties below, we see that there is an additional $6.35 PMPM, and that come up to about 8.75 $2.75 lower, which is about 25.4% lower than the head model. And this is very consistent with the information that we see on slide 5 when we look at the total PMPM spending, for 2022 at $25.74 and $34.48. Next slide, please. So one may say, well, why is it actually lower? When we look at, we did a crosswalk between for the same specialty codes or specialties. What we did a crosswalk of the specialty codes and the taxonomy codes, and we see that there are less specialty codes, well, not specialty codes, but taxonomy codes for the primary care investment work group than the head model. System is very, very low as far as the primary care investment is concerned. So that is one of the main reasons why we have a higher PMPM when we look at the same specialties between the primary care investment work group and the head model. Next slide, please. Now we attempt to see, well, what is the impact in adding the gynecology specialties and psychiatry. So we see that when we look at the primary care, when we add these specialties, the gynecologists and the psychiatry, we see that it added about $6.31 to the $25.74, or about 25.5% increase in spending when we add those two specialties in psychiatry and OBGYN. Also, there's a other specialty in the head model, preventive medicine, which add just about 4 cents, or about 0.31% to the spending. So when we look at all of these, we see that there's an overall increase in spending of about 24 or 25%. Next slide, please. And lastly, we want to see, well, what is the impact in adding the FQHC? We see it's very, very negligible. It's about only 0.01% increase in the primary care spending for the primary care investment model. Next slide, please. That's the end of my presentation.
Thank you, Kenneth, for your participation on this presentation. Appreciate it. So we are mindful of time. So if there are questions about these particular slides that come to mind, if you email them to us, we'll be happy to address them. Or if you wish to just drop it in the meeting chat, we'll also address them through that mechanism. With that, let me turn this back over to Dr. Reedman for bringing us to closure.
Yeah, David, if I could just interrupt, I think in terms of thinking about the definitions, the multi-state definition versus the head model definitions, it's notable that this is probably not a decision that's completely within the control of the state. The head model definitely has multiple states, 4 tentatively for the cohort 1. I don't believe they've announced formally cohort 2 yet, but that's an important monitoring tool that apparently CMMI is going to use. The advantage of the multi-state definition is it would allow comparisons across both states that are in the AHEAD program and other programs, or perhaps not even participating at anything at all. So it would have wider application. I think that typically the definition used by the multi-state, which we call the PCIW definition, was vetted across a range of states. It sort of took root in New England under the leadership of the New England APCD states and the Milbank Foundation. but certainly is used by a range of states today. I think everyone can have that perspective about whether the additional specialties defined in a head belong there or not. But clearly there are advantages as we shoot towards a target to having one target as opposed to two. But it is not unusual when one works with government that organizations keep two sets of books. And so I think it is possible to have two models. Two targets may not be absolutely optimal, but I think what we're, as we close this meeting, would really like everyone, both in the PCIW as well as the other two work groups, to think about advantages and disadvantages of the two approaches, some combination thereof, or further winnowing of the process. Very important to emphasize that using the head model in some dimensions is not going to be the state of Maryland's call only. So I'll pass it back to you, David.
Thank you, Ben, for the feedback. Dr. Reedman.
Thanks, Ben. And in particular, thank everyone for the time this evening. It's always enlightening, and I'm always excited to see the passion and compassion that the people in the state have for what we're doing and what we're trying to accomplish. So in particular, thanks to the secretary for taking her time on this. And I look forward to our next meeting. And I know we all have a hard stop, so I'll end the meeting and thank everyone again, and have a great weekend and a great rest of your summer that's closing out.
And I think the secretary might have a comment.
No, I was just going to thank everyone. I really appreciate the feedback as we continue to build this out. So, and the level of engagement was really exciting. So thank you.
Thank you very much. So everyone have a great evening, and thanks again for your participation. And we look forward to talking to you again soon. Be well all.
Thank you. Thank you.
David, I just put everybody back in the waiting room. I don't know if you're still there.